Okay, so first I would like to thank the board members of the AGSD for allowing me to come here, as well as the sponsors for making this happen. You know, it's a great thing to see everyone advocating for diseases that are very close to our hearts because we love our patients that we care for. So I'm going to try to give you a journey through what has been happening for GSD over the years. I will start with what is known to happen or what we do usually, and then I'll go to the new things that we're seeing in the advances and the repurposing of drugs and so forth, but not with details on any one of them because I know there are other speakers that have prepared very lengthy presentations to address these new treatments and interventions. So the only disclosures I have is I am involved in 2 clinical trials right now that treat patients with GSD1A, and I did have a PI-initiated trial that I use triheptanoin for patients with GSD1. So as we know, the sources of blood glucose come mainly from diet, but then the rest of the glucose when diet is weared off, like meaning we broke down the food that we ate, comes from stores, and the glycogen stores need to break down, this is glycogenolysis, in order to have a supply of glucose available when the body needs it, or do something called gluconeogenesis, meaning from genesis is making new glucose from other, what we call substrates, but that word means other substances. For example, amino acids or glycerol, fat, and so forth. So those are the ways that we continue or our body continues to provide glucose when needed because glucose is the primary fuel for the brain, so it's very important. So glycogen has to be in a shape and form that allows the glucose to be available. And this has a structure. So it has a structure that looks like a tree with branches. And in order for it to be soluble and break down fast when needed, these branches have to look like a certain structure, and it has to have proteins or what we call enzymes that allow these structures to be broken down in the right way. So they have to be made in the right way, and that's what we call synthesis, and then broken in the right way, and that's what we call degradation, and that's part of the metabolism of carbohydrates. Okay? That will allow it to be easily mobilized and broken down to the blood when there's a time of need. And what is the time of need? Is if we're fasting, or if we're not eating, or if we're simply exercising too much and the body needs more. So glycogen in the liver acts as a short-term storage deposit. So the time of need can happen because, for example, someone is at work and didn't eat, had to skip lunch. For GSD, we know that's detrimental or very dangerous, okay? But the idea is the body usually is able to break down the stores and supply enough glucose to prevent that from happening, except, for example, the worst condition is GSD1 in general, because they neither have gluconeogenesis, meaning they cannot make new glucose from the substances that they have from proteins and so forth. And then the other reason is they do not have glycogenolysis, so they cannot break down their glycogen stores when needed. So GSD1 in general is the hardest. It's the most difficult when it comes to access to glucose in the time of need. The other place where glycogen is stored is the muscle. And you can imagine why? Because the muscle, when it's active, depends on glucose as a source of energy. So glucose is the fuel for the active muscle. Resting muscle can use fat, but active muscle likes to use glucose. Okay? So this is an important, one of the diagrams. So I'm not going to show too many of them, but it's important because it shows what we are dealing with on a daily matter in order to maintain the glycogen stores the way that they should be. Okay, so in a normal situation, the glycogen synthesis and the glycogen breakdown do not happen at the same time. So in a fed state, when you eat, glycogen synthesis starts, meaning insulin goes up. And the reason why insulin goes up is you don't want your blood sugars to be consistently high all the time. So insulin is physiological, meaning it has a job to do. And what it does is it starts, doing some things that allow the synthesis of the glycogen. It starts the process of making glycogen get stored in the liver, and then at the same time, it makes the triglycerides or the fat also synthesis, so what we call lipogenesis. So I just want to explain, at that time, during the glycogen synthesis, the breakdown of sugar is not there. So when that is turned on, you're going to see high here, I to G. I is insulin, and G is glucagon. Glucagon is another hormone that is supposed to actually work and be high if the blood sugar is low. So basically, there's a relationship between insulin and glucagon, where when you need sugar, you're going to have more glucagon and less insulin. And then when you're making the stores, you need more insulin, so after you eat, and you need less glucagon. And the branches here that you see, so this glucose 1-phosphate, in order for it to happen and to be the starting point where what we say breaking down of sugar happens, you have to have synthesis of glucose. And the patients who have problems with glycogen synthase, that's GSD 0. So you can see there's problems where you can't make a glycogen, and then the brancher defect is also on the synthesis side, and the brancher is GSD 4, okay? So every disorder on the pathway is associated with an enzyme or a protein that is necessary for the process to take place. If that protein is not working, then you're going to have a problem, okay? So you need the right structure of the glycogen in order for it to work. So it has to have the right shape of the tree and brancher from its name, so it increases those linkages, okay? And then after that, when you're in a state where, okay, now you need sugar, it turns on to the other side. Insulin becomes suppressed, means goes down, and then glucagon is higher. In GSD1, glucagon does not work because they don't have glycogenolysis and they don't have gluconeogenesis. So that's why they have to eat and take cornstarch, because this mechanism is not going to work. It's not going to save them in the time of need. Now, when you see that on that end, you have to start breaking down sugar, so then you have to have that debrancher. So from branching in synthesis to start a breakdown is a debrancher. Debrancher is the defect in GSD3, okay? And then we have glycogen phosphorylase. So we've got a muscle phosphorylase and a liver phosphorylase. The muscle phosphorylase is McArdle for patients who know about GSD type 5 that leads to muscle disease. And then the liver phosphorylase is actually GSD6, and I know Dr. Kishnani is going to talk about that one. So as you see here, every enzyme and step in the pathway, if there's a mutation, a DNA change that led to blocking of that pathway because this enzyme is not working, it's going to lead to a GSD disease. And as we go down that pathway, this glucose 6-phosphate and phosphatase, that's the one that's associated with GSD 1A when we say glucose phosphatase complex, and then 1B when we talk about the transporter defect. And this is very important because GSD 1A and 1B are the most common type, but it's also the more severe type. And I want to say that there are multiple enzymes throughout the pathway that are involved in this whole process of breakdown of glucose, and that's the step of glycogenolysis, okay? So glycogen storage disorders, there are a group that are hepatic, meaning primarily liver disease. They're all genetic, meaning they're inherited by a mutation in the DNA. And then we've got a group of disorders that are muscle primarily. And then we have a group of disorders that are both muscle and liver, okay? So this is, I don't think that you can see it that well, but if you do, this is a timeline that I got from a paper that Kathy Ross and Dr. Ryan was involved in this paper who spoke yesterday about the history, and it just shows you when each of these disorders, so Van Gurk discovered GSD type 1 in 1929, and then you can see the timeline of the other conditions, and you can see that there are some that were named differently and changed. I'm going to talk about one of them today, Fanconi-Bickel, just in short, like a summary type of thing. So glycogen storage disorders and type, the predominantly hepatic are the ones that are primarily, the enzymes are in the liver, and some of them have also enzymes in the muscle. GSD1 does not. So GSD1 is primarily liver, okay? But it also has, the enzyme is the second organ involved in GSD1, just as a reminder and an important one, is the kidney. okay? So 75% of glycogen and glycogen storage metabolism occurs in the liver, 25% is in the kidney. So the kidney is a very important organ in this disease. And that should be on the mind of any of the scientists and researchers who are working in this area, that we want to save the liver and prevent disease to the kidney. Okay? So GSD 0 is glycogen synthase defect, and then you can see 3 is that debranching enzyme. And I'm going to talk about 3 in a few words and say GSD 3 is 3A and B. 3A has muscle disease and heart disease, okay? 3B is primarily only liver disease. So there's a big difference in the presentation and a big difference in the response to treatment. So you can imagine that. Now, 3A and 3B have a different thing about them. It's not only glucose going down. That's only one of their problems. And the glucose can actually be maintained and not be so hard and difficult to treat as in GSD1. But the other problem is quantity is the glucose being low, quality is the type of the structure of the glycogen is abnormal. We're talking about a debrancher defect, so the structure of the glycogen is abnormal, and that leads to a harmful effect when it deposits in the liver as well as in the muscle, okay? So coming back to GSD type 4, they can have low blood sugar, but it's not the primary thing. The primary thing, again, is an abnormal structure to the glycogen, so it's what we call quality of the glycogen, and that leads to deposition, again, could be in the liver primarily for GSD4, or in the muscles, or in the heart, or in the adults. They have something called the late onset disease, which is called adult polyglucosan body disease. And I just want to mention that GSD type 4, the shape of the glycogen in the adult abnormality, they can have the abnormality in the liver but not cause disease, but the main presentation is in the nervous system. So these patients present with bladder problems, with weakness in the extremities, with peripheral nerve problems, totally different disorder, okay? And then I want to talk about, just mention GSD 6 and 9, but I know Priya's going to talk in details. I do want to talk about the so-called GSD type 11, which was so-called because it was called, it has another name, it's Fanconi-Bickel syndrome, but it was called the GSD because it looks like it, but it's not a GSD. So it is not in the pathway, neither of making the glycogen nor breaking it down. Instead, it's a transporter defect. It's caused by a mutation in something called GLUT2. So what does that mean? That transporter expression, meaning it is in the liver, kidney, and intestine. So these patients do not absorb glucose galactose well. And that leads to a problem with the liver being large. It leads to a problem where the kidney is spilling out a lot of products. These products include potassium, phosphorus, magnesium, calcium. So they can develop rickets. So their manifestations is different than the other type of GSDs. And their treatment can be similar, but they're allowed to get fructose. They're not allowed to get milk. Galactose, no, okay? So the treatment is different. They require supplements. All of the phosphorus, potassium, calcium that they lose, they need that supplements. And if you treat them early, they will do well. I mean, I've had 2 patients that came from a different country, and basically they were wheelchair-based, and when we started them on therapy, they were on their feet and they were moving around. So it's a disease that is treatable. You just have to be able to make the diagnosis and the supplements as needed. They also lose something called carnitine in the urine, and carnitine is very important because carnitine will take the fat from the blood and give it to the mitochondria to change it to a source of energy. So you have to also support or supplement carnitine in these patients. Okay, for the predominantly muscle disease, we know about GSD type 2, which is Pompe disease, and this is different than the other GSDs because it's in the lysosome. So all these other diseases were in the cytoplasm, meaning if I take you back to biology, if the cell contains, a nucleus, that's where the DNA is, the rest of all what floats in the cell is in something called the cytoplasm, and then there's this little organelle called the lysosome, little, but does a lot of work. It's like the recycler of the whole cell. So GSD type 2 is a lysosomal, different disorder. And that's why the treatment can be through something called enzyme replacement therapy, because you can target this lysosome through a certain receptor that knows where the mutation is in the lysosome and fixes it. That's not easy or possible right now with the cytoplasm condition. So ERT is not available for the other types of GSDs. Just explaining that. The only one is GSD type 2, that is lysosomal. And then the muscle phosphorylase is McArdle disease, and we have phosphofructokinase. I don't know if anyone here has GSD type 5 or 7, but I'm happy to talk about them in details if they wish to talk to me about that after that. So the problem with GSDs in general primarily is hypoglycemia or fuel shortage. And in that case, it's important to understand where is it coming from. It's either a problem in the synthesis, making it, or the breakdown of glycogen. Or you have a problem with the structure of the glycogen, and it's just not giving you a good quality of sugar, okay? This is just an important slide to understand that when it comes to GSD1, again, it is a different condition because it has not only a problem with hypoglycemia, but the consequences of that hypoglycemia related to where the gene mutation is leads to a problem with the metabolic pathways that are close by or act at the same time. So if you have a block in the glucose 6-phosphatase, do you see where I'm pointing? So instead of making sugar, you're not going to make it, you're going to go backwards. And what you go backwards is you have excessive something called glucose 1-phosphate. That is supposed to move the cycle in a direction where you make more glucose, and instead, what happens is it accumulates and it goes into other pathways. So it goes into a pathway that increases the uric acid, and that's why they have a lot of uric acid and gout. And then it goes into another pathway downstairs here to pyruvate, and it increases the lactate. And then with the lactate, when it increases, it also increases alanine. And then it also increases acetyl-CoA, which is something that's used for fat synthesis. So that's why they have a lot of triglycerides and problems when you don't have the right environment for the synthesis of triglycerides. It ends up in the liver, causing steatosis or a fatty liver. And that's why when you correct the metabolic condition, which is maintaining the blood sugar within levels that are normal, you shut off all these excessive alternative pathways that is there. So that's important to keep in mind. So the organs involved in GSD is also different. You have in GSD 1, A and B, the liver and kidney. Then add to it in B, you've got the neutrophils, okay? And the intestine, because these patients also have an ulcerative colitis, what we call a colitis-like picture, okay? GSD 3A, liver, muscle, and or heart. And then GSD 3B is liver only. And then GSD 4, liver plus muscle and heart. And then Fanconi-Bickel syndrome, not a GSD, so it's a misnomer. It is a transporter defect, and it's due to GLUT2 defect, and it affects the liver, kidney, intestines, and bone skeleton. Okay? This was the paper that I was talking about that Kathy Ross and the group and David Weinstein, had a very nice review of the historical information leading to the dietary requirements and challenges and controversies about using, the diet and should you use a ketogenic diet or not. So a lot of these are addressed in this paper, so I'm just bringing it up here in case if anyone's interested. I think it's a good paper to look into. I just want to say I summarized what they had here on the evolution of therapies over time. Believe it or not, they were doing portocaval shunts. Portocaval shunts in the past, this is a surgical procedure where they were doing that to bypass the absorption of carbohydrates. So you can imagine how intensive that was. And it's a big deal, but it had to happen because at that time, cornstarch was not discovered. And these children were dying. So I want to say the whole scope of the treatment has changed since that time, and our children are doing so well. And yesterday, as we were mentioning, the natural history of the age has grown so much, and there's with a lot of good care, the risks of complications have become less. So other therapies where the continuous glucose, they put them on infusion. You can't live on glucose only your whole life. Or TPN, where they would hook them up to an IV because their nutritional state was so bad. These patients did not want to eat and drink, and they were small in their growth and so forth, potentially very, not doing well in their height and so forth. And then came the continuous feeds and the NG versus G-tube, and then understanding more about the carbohydrates, and we should increase the carbohydrates, and then uncooked cornstarch came back around late 1970s, early 1980s, and then came glyphosate, the modified cornstarch, to help with nighttime maintenance, and then the supplements that are always needed, because these patients have problems with vitamin D deficiency, have problems with iron deficiency, chronic illness, as well as if they have an adenoma, hepcidin expression, and so forth. And then you have for GSD1B, there was the GCSF, because that was the way that they would increase the white blood cell count because these patients had neutropenia. And then for the gout, they were giving them allopurinol. So the ideas from there, we started understanding more about what could we do to treat these patients and optimize the diet. So we started saying, okay, frequent meals, because nutrition is important. I can't give someone cornstarch without proteins, without fat, because those are necessary in order to allow the growth to be accurate and good. Now, I just want to let you know, amino acids, arginine promotes growth. It promotes growth hormone. So if you're taking only cornstarch and you're not eating proteins, you're going to have a problem, okay? So you can't depend on cornstarch alone, and cornstarch doesn't work until age 1 year old, because that's the time where the pancreas matures and you're able to use it. Okay, so uncooked cornstarch was discovered, and it made a big difference. I know that this happened at Duke, so I'm not giving a shout out to Duke on that because I'm there, but I just want to say it was by a physician that was very dedicated, YT Chen, and I believe Priya Kashani was there at that time as well. But it was dedicated to save the life of the patients, okay? And it did make a difference. And then specialized care is very important. So remember that we do not work on an island, we work together. So in the presence of a disorder where there's problems with growth potential, endocrine is needed. There's always the need for dietitians, the metabolic dietitians, the hepatologists at a time where we're managing GSD3 in particular and 4, as well as GSD1 if adenomas start showing up or changes are significantly happening where the liver size is increasing and we want to know what's going on there, okay? Nephrologists are very important because, again, these patients with GSD1A, for example, and B can have kidney problems and proteinuria or, protein loss in the urine, and then the cardiologists for the GSDs like 3 and 4 where cardiology is needed. The uncooked cornstarch has provided a way to stabilize the glucose between the frequent meals. And the idea about the uncooked cornstarch is it has to be not exposed to humidity and not used with warm water because that ruins it. It has to be uncooked, okay? And that will lead to, it's a complex carb, it will lead to slow release of glucose, and then when it gets broken down, it actually secretes or allows the glucose to be gradually absorbed. That has helped a lot, and nighttime dosing has to be done in a way where it allows the patient to sleep, like every 3 hours or every 4 hours, depending on how long it can work for them. But there are other things that over time we learned about, and we have to add to that component to work out well. One of them is avoid the high glycemic index foods. So it's not only the quantity of what we give, cornstarch and so forth, or the type of carbohydrates in terms of amount, but it's also the quality. So the high glycemic index foods are the ones that are like simple sugars, okay? Fruits and things like that, where if you eat it, it's going to raise your blood sugar really fast if you're low, but then it's going to come down fast because you're going to have a spike of insulin. The low glycemic index foods are the more complex carbs that take a longer time to last, and I think it's very important to keep that in mind too when the diet is being prescribed. Complex carbohydrates are definitely better, and the ones that have grains and legumes and vegetables are very helpful, and that helps also provide and stabilize the blood sugars without lots of peaks from insulin. And then avoid the simple sugars. Now, this is controversial and variable. I know some countries in Europe do not, agree with avoiding the simple sugars, but I've used it in my practice, and it has helped with the patients because they don't get used to it at a young age. And then after that, as they grow and you allow some liberalization, they don't excessively, go on it and have problems with it. Protein intake is important. So in patients with GSD1, in general, I just want to bring this out. The recommended daily allowance is what's recommended. If you give them too much and they're not under good control, It's going to go into alternate pathway breaking down, and they're going to have high uric acids and gouty attacks. So watch out from high proteins in patients with GSD1 because it's not helpful, okay? They can't utilize it well. Now, what about GSD 3, 6, and 9? So these are a different group of disorders. They have what we call ketotic hypoglycemia. GSD1 have none or hypoketotic hypoglycemia. They don't make ketones. But the difference is also in the physiology. Remember when I talked about GSD1, that is the hardest to treat and the hardest to maintain because they have problem with gluconeogenesis, making new glucose from other things like proteins, and glycogenolysis. Well, 3, 6, and 9, gluconeogenesis is intact. So if you give them protein, they can use it to make sugar, okay? So high protein can be utilized, and it's a good thing to do. Lipid management is very important for both groups because triglycerides can be elevated, and it's something that's important to prevent because you don't want fat to deposit in the liver and cause steatosis. I just want to say, some patients with GSD1 have ALT and AST elevation. Where's that coming from? Is when you have too much fat deposited in liver, sometimes you can have an inflammation on top, and that's called steatohepatitis. Hepatitis means an inflammation in the liver. And if that persists for a long time, that can lead to complications of its own and changes in the liver that you don't want to happen, okay? So it's important to keep an eye on the triglycerides and make sure that they're maintained within normal levels. Supplements are important. Maintaining the blood sugar 24/7 in a normal state is important. If you get all of those right, you won't have hypertriglyceride. And I know it as a fact. I'm very proud to say I had a very diligent group of patients that followed this and did very, very well. And their numbers were just like normal. Triglycerides within 125, 200 max range, uric acid normal, lactate normal. So this can happen through diet. It's just the regimen. Everyone will keep on saying, when will my life get better? I have to take cornstarch around the clock. I have to eat around the clock. So even though diet is the cornerstone right now and the standard of care, we know that there's a lot of complexities that occur with it and a lot of restrictions that occur with it, okay? Even with the uncooked cornstarch that came and changed the face of treatment of glycogen storage disease, came also with, can all the patients tolerate it? Because some patients don't do so good with cornstarch, especially at the beginning. So they can have GI discomfort. Some of them even have required pancreatic enzymes to fix that. You know, there can be weight gain at a time. There can be high blood sugars, you know, and hyperglycemia that happens, and that leads to a bit of a problem because insulin can spike with that as well. So what I want to say is everything has a benefit as well as some risk of complications. Glyphosate came in as a modified form of cornstarch with a high amylopectin. So the branches of the tree are bigger, and that allows it, when it gets broken down, to be released in a slower form and maintains the blood sugar because it has what we call that low glycemic index. It doesn't have a peak of insulin, so it lasts for a longer time. The problem is if you give glyphosate at a time when blood sugar is not controlled, glyphosate will not hold. So glyphosate's job is not to increase your blood sugar or a treatment alternative to cornstarch. It's to maintain cornstarch. So you have to be normal under, you know, have normal levels and under good control before you start glyphosate. And it has, you know, been a blessing to many of the patients who have used it at night and been able to get better sleep. Okay? And then this is a study, or triheptanoid and MC2 oil. I'm just going to mention it because I had a PI-initiated study in it. I'm just going to go over it and say triheptanoid, which is a fatty acid. So it's a glycerol odd-chain fatty acid, can sometimes be given because it forms energy and it provides, when it breaks down in its oil form, substrates that go into the energy cycle in the mitochondria. So it has been studied in GSD1. I have a study, and if anyone has questions, you can ask me about that. And we're not continuing it, and I'll say why. And then it also has been done in the adult polyglucosan disease. Adult polyglucosan disease, it didn't have side effects, but it wasn't helpful, okay? In GSD3, I have one patient that continues to be on it, and she has actually done very well with it. So it has stabilized the heart condition because, again, patients with GSD1 different than 3. 3 can use high protein, and then when high protein becomes, you give them the high protein and it's not enough, you have to add something else, and triheptanoid makes them on the ketogenic side. So it was very helpful to stable a condition. MCT oil is also a fatty acid, but it's even chained. It doesn't break down to the same number of benefits that triheptanoid has, but just to tell you, in the study that I had in GSD1 patients, there were 4 patients involved. It reduced the elevated ALT, AST in the patient that had very high levels that were not coming down, and this was a child, so it was very important. And then it reduced the steatosis and stabilized the heart. And I can tell you, the patient wanted to go into a gene therapy study, so he went off it, and everything came back. So I could say that the effect of the triheptanoid was very helpful in that patient. The cons, and this is why I'm saying, and we're not continuing to do it, is you add it on top of the cornstarch, on top of the feeding, and you have to put it in a place where it doesn't impinge on the levels of the others, because if you put it with the carbs in the cornstarch, it increases the risk of diarrhea. And if you put it with the regular food, you have to choose a low glycemic index. So again, another regimen. And the families basically said, we want to take out from the schedule, not add another element. So I get it, I hear you. And that's what I'll write in the paper when it gets published, okay? So are there other ways to treat? And that's the whole idea. Is there a way to ease the diet and the cornstarch regimen? And here's the idea about new therapies. Not only because they need a new therapy because they're tired of having to do what they do every day, but it's also because still there are long-term complications that happens in these patients, and some of them irrelevant of control. But usually most of the patients who are in the younger age who started out well, if they continue that way, there's a delay in these complications. So you see 1A and 1B can have this HCAs, hepatocellular carcinoma, tumors in the liver. They can have adenomas, and that adenoma is a benign tumor that switches to or changes to a cancer tumor when the size is big. So if any patient has an adenoma and the adenoma size increases more than 6 centimeters, that's a telltale sign, watch out. Because if it goes up higher than 6, that can either be cancer in it, or there's a risk that it's going to rupture and bleed and cause an emergency thing to happen. So those patients are ones to be very careful, and they need to follow up with, I would say in that case, a transplant team. I'm going to give a talk about liver transplantation, how it's not a taboo and that sometimes it's needed. So I just want to say sometimes it's needed, okay? Osteoporosis, kidney stones, polycystic ovary disorders, these complications happen more in the generation where the treatment and the control was not perfect. You know, with the younger generations, we hope we don't see that, but we have to follow them over time and see how things go. GSD1B, of course, repeated infections, and now, again, we're hoping with the new treatments that we are able to avert these problems. Okay, GSD3, so 3, remember, you can fix the hypoglycemia, but what about the progressive nature of the disease with this abnormal structure of glycogen depositing in the liver? How are you going to stop that? Till now, we're not able to. Diet does not fix it, so they can continue to develop fibrosis and cirrhosis in the liver, and then they come to an age where they have to have a liver transplant because the liver fails. So we want to try to prevent this at a young age so they don't have to go through that. Same for 6 and 9, and as I said, I'll leave that to Priya. So let's go to what are the therapies? What are the forms of gene therapy or therapies? Gene therapy is just one aspect, but what are the forms of therapies that might work for GSDs? So gene therapy helps fix the underlying gene that's missing, and that can be used through these adeno-associated viruses, vectors, and that can deliver functional genes to the liver cells, and that can restore the function. The point is, it targets to the only organ that it's supposed to be targeting to. It won't go to the others. So if you have a problem with GSD1, it's going to go to the liver. It's going to do its job if it reaches there and works out well, but it won't go to the kidney. So is it going to help? Is it going to prevent disease in the kidney? We don't know, because these are ongoing studies that we're still working on. And I know Dr. Rebecca Reba is going to be talking about what we have on these studies for now, the clinical trial ones. So I'm not going to go into details on that. But it is a potential for long-term management in these patients. And then we have gene editing. And gene editing technology uses different tools. So there's CRISPR-Cas9, there's adenine-based editing, there's prime editing. And I know Dr. Dwight Kubrel is going to be talking about the gene editing, so I'm going to leave that to him. There's RNA approaches. The RNA approaches for GSD, you can either, deliver a messenger RNA, and there are shapes and forms. You heard Moderna's talk yesterday that uses the nanoparticles to target the liver. Again, targeting the liver, not the kidney. So again, remember, GSD1, targeting the liver, not to the kidney, does not cure the disease because it's still in another organ. And that's very important to understand. For patients where we're saying gene therapy is coming in, it is fixing, if any, the liver condition, not curing the disease. It is not curative at this point in time. To be curative, you have to fix all the problems. Now, if you tell me, is there going to be a treatment for GSD3? Yes, we hope. But if you think about who's going to benefit, it's GSD3B because they only have liver disease. So it may cure that one, but it's not going to cure A because A, you have to, in your treatment, think of what's going to happen to the muscle, what's going to happen to the heart, okay? And then there's this RNA, what we call interfering or small interfering RNA. And these exert effects on certain elements in the pathway that when there's a synthesis, for example, that is happening and you want to break down or stop the abnormal shape and form from happening, should we use things that block the pathway in areas so that synthesis of that abnormal shape and form is not excessive? So that's where that siRNA can come in as a treatment. And here it sometimes can silence the glycogen synthase. The point is, how are you going to be able to limit the amount and so forth? So that's a challenge. I'm going to leave it to the scientists and researchers who are working on it. So right now for GSD1A, we have active clinical trials, gene therapy using adeno-associated virus 8, the ultragenic study. Phase 1/2 has been completed. Phase 3 is currently ongoing. They're not enrolling because they are already in the treatment and crossover part. Messenger RNA is currently in phase 1/2, and this study is enrolling. They have a single dose type of style trial where they're trying to find which is the best dose and what is the best frequency that this medication will be given for. It's one that is going to be repeated, so it's not a one-time shot. It's, for example, every 2 weeks or every 3 weeks, depending on what the response is going to look like. Okay? And then we have other emerging therapies that are on the preclinical side. So there's something called splice switching oligonucleotide-based therapy. Please don't hate me for going through all these very difficult, what seems to be difficult. I just want to show you that there's hope. Okay? There are people who are thinking in different pathways to make sure that there is a way that will be able to fix things. Okay? And that is a good thing. In this condition, it's still in the preclinical phase, meaning it's mice studies, and they're looking at one specific variant, and this was a variant that's common in the Asian population. Okay? And then there's adenine-based editors, and that is through the BEAM therapeutic study. So BEAM is one of the new trials that are setting up, so I don't think that they've started yet. But they have a specific gene mutation that is more common in the Ashkenazi Jewish population, and they're addressing only that mutation. It's also a very common gene mutation in the GSD population. So that's what they're working on. And then there's other gene editing, and as I said, I will leave that to Dr. Kubrel. For GSD1B, there's new therapies. There's the SGL2 inhibitors. The common drug is called empagliflozin, which is a mouthful for me, but the other name is Jardiance. And I know I think Dr. Dirks is going to talk about it today, so I'm not going to go too much into it. But the idea about it is this was a drug used for diabetes, and it got repurposed to GSD1B because simply it can get rid of a toxic level of accumulation of that 1,5-AG pace in the blood, and which is the cause of the neutropenia, meaning the white blood cell coming down, and the abnormal neutrophil dysfunction. So by repurposing a known drug, you're able to, you know what the profile of the drug, safety profile is, but you are giving it a different shape and form and function to do. Okay, and as I said, because I know this is going to be spoken about, the drug is mainly to get rid of that toxic substance in the urine, and then by doing that, the neutrophil function improves, and the risk of infections in GSD1B lessens, okay? Then there's messenger RNA replacement for GSD1B. So I'm now in the therapies that are coming in for GSD1B. There's Cure GSD1B, is focusing on messenger RNA replacement therapy. How that's going to happen is something that is still in the works, and they're collaborating with research in mouse studies to explore that further. And then there's another study called Prime Editing for GSD1B. Prime Medicine is advancing again, the editing mechanism, and they are targeting a certain mutation that I've labeled here. So again, when it comes to gene editing, sometimes it can only fix one mutation, and other times it can fix many. And I think Dr. Krubel is going to tell us the difference between the two. And then emerging therapies for GSD3, we know that debranching has a problem with the shape and form of glycogen. There is an investigational messenger RNA therapy developed by Ultragenyx for the treatment of GSD3. I believe it goes through an encapsulated lipid nanoparticle, and it was in a phase 1-2 trial to evaluate safety and tolerability. I believe it is not recruiting currently, it's on the hold. And for GSD3, there's also other hopes and things coming in the future, including a new treatment strategy by Genethon. And they designed what we call a truncated functional version of the debrancher enzyme. I just want to say, this is a tricky one because debrancher, the gene is huge. So when we try to put a vector in a gene in a vector is the carrier, is the virus that's going to carry it. So adeno-associated virus, the size is too big for it. So they have to come with an idea, is what is the best way that you make or create a vehicle or a vector that's going to carry that size of the gene. So here they have designed like a truncated functional version of the enzyme, and it's going to be transported to the cells, and it's going to be using an adeno-associated virus. So definitely that's an approach to, hopefully help the, the patients with this disease. And I think there might be some discussion about that here in this meeting. Other preclinical trials at Duke are currently, in the makes, addressing the same thing, and the main challenge is, again, the large size of the gene. And I know that there were preliminary studies in mice models as well as dog models, and it's ongoing in the Kishnani Bodong Sun lab that are still in progress. Other emerging therapies, what about enzyme replacement therapy in these patients? So again, we've talked about the fact that these patients, the disease is in the cytoplasm, but there was an idea sometimes, well, what if they have too much of the glycogen that accumulates, and would giving them something like the enzyme that they use for Pompe help get rid of whatever goes to the lysosome, because that's the recycler of the cell? Maybe. So that's something, that has been addressed in the past, but I don't have too much information about it. There's pharmacological approaches. The rapamycin is an mTOR inhibitor, and that helps with decreasing inflammation, and autophagy. Autophagy means the way that the cell gets eaten up and get rid of it. So again, when you have an abnormal structure of a protein, it doesn't stay for long, okay? So things happen in the cell where you have to get rid of it. So there are things where they think of either blocking the synthase that produces the product, okay, to try to prevent that accumulation of the abnormal product shape and form. And then I just want to say that this ERT, although I said it doesn't work for GSD3 at this point in time, it has worked beautifully for Pompe disease, and there are different shapes and forms of it. Although, in Pompe, the types of the enzyme replacement therapy are changing because not all of them deliver the enzyme to the different organs at the same efficiency, okay? So Pompe is a disease that has heart and has problems with the muscle and so forth, so that's another situation. And then there's something called small molecule therapies. So small molecule therapies are actually compounds that are used and can be used in a way where they target certain things in the cells. So there's this PTG100, which is called protein targeting to glycogen. And that activates something called an enzyme called glycogen phosphorylase. If you remember, the phosphorylase is the one in the pathway that leads to degradation, breakdown in the glycogen. And that's actually the same enzyme that is for GSD6. Okay? So this would enhance the synthesis, but at the same time improve the breakdown. So there are small molecules that may take a role. So if you ask me right now, are they using these in patients? No. Okay? This is still very preclinical. There are small molecule inhibitors. So this is glycogen synthase type 1, which limits the enzyme muscle glycogen in the muscle. So I'm going to say, at the same thought process, you want to try to block a pathway if it's leading to accumulation of an abnormal shape and structure of glycogen. Okay? There's another drug for adult polyglucosan disease, which is GSD4, called Guaiacol. And this is a product that stimulates actually insulin and makes the insulin kind of take a hand in changing the balance between what is synthesized and what is broken down. And there's even mitochondrial reprogramming. I mean, so these are another way that you can actually provide energy production and improve. So again, we talk about GSD1, they don't make ketones. So here, by providing this bempedoic acid, it reduces a certain enzyme that's important in the production of energy through the mitochondria and fatty acid oxidation. So it's using or increasing the fat oxidation in order to bring in another source of energy, okay? And then transplant. And I just want to say, it is not a bad thing when it's needed. It is an amazing thing when it's needed. You can imagine that a person who is a donor, meaning someone may have either died and is giving you a gift, or someone who has, for example, been a partial donor or a living donor who is giving part of their liver to help someone else. So when it's needed, it's needed. And the point is, it can be needed for liver transplant, for kidney transplant in patients with GSD1, 1A or 1B who have the kidney disease. And when they have kidney disease, it is better to do liver and kidney because that will allow improving the metabolic state as well as the kidney condition in the same time when you're getting the immune suppression. So rather than get a kidney and then after that it fails because the liver is still having problems, and with the immune rejection drugs has more problems, and then you end up having to have another surgery for the liver. So think about it this way. Transplant, when it's indicated, it is a good thing, not a bad thing, okay? Bone marrow here comes before the GSD1B because sometimes they're at risk of having malignancies, including myeloid leukemia and so forth. I'm not saying that that's a common thing, but it can happen. Okay, heart transplant primarily for GSD3A or GSD type 4 if needed, and that might be liver plus heart in that case, okay? And then the organ transplant, just to let you know, is a form of gene therapy because it replaces the gene that's missing. So you get actually the normal gene, okay? And then I am blessed by taking care of so many children that have GSD in different shapes and forms, and I can say this couple is here, and I'm hoping that they're okay with me showing their picture because I know it took it a long time ago, and now they're older, but they have allowed me in the past to use it when it comes to scientific groups. But I just want to say it is a blessing to have. So if you ask me how many children do you have, I say I have so many because I've had the honor of taking care of young lives and seeing them grow so beautiful to become, you know, so productive and creative in every single way. So this is one of the children that I had with, who is, you know, now I think about 12 years old, and she has GSD3, but she wants to be a doctor. I don't know if she's going to continue to do that, but I can tell you, I'm from Egypt, and her shirt, if you look at that, it says someone in Egypt loves me. So that tells you, I always remember them, even when I'm in Egypt, okay? And of course, this can't happen without, you know, being, working among a group of people that are just dedicated to the care of these patients. And, you know, at Duke and previously in Pittsburgh, we were dedicated to the care of these patients. And here I just want to, you know, give a shout out to all my colleagues who help us always maintain our goals in trying to help the patients. And thank you, and I'm ready for questions. Am I quickly on time?
No, we have a couple. If
Okay.
anyone has any questions, we have a few seconds. Anybody? Yeah.
Thank you very much for the presentation, really good information. Just one quick question around the gene therapy and the gene editing. Did you say that these are only possibilities that affect the types that affect the liver only? Or could they be used for types that are for different organs, but if they do, then it's only going to be targeting the liver only?
So very good question. I just want to explain that every gene therapy is going to be designated to a specific disease. So for example, if we're doing gene therapy for GSD1, it's going to be only for the mutations related to GSD1. Same for GSD, because again, the gene is different in 1A than 1B. So you can't give someone with 1B what you're giving for 1A. Same thing for GSD3, you have to use the same gene, okay? What I want to say is the target of the liver versus heart versus the organ. The liver is a favorable organ. I'm going to be talking about liver transplant tomorrow. And I'm going to say, why is it a favorable organ? So first thing, it has a tolerogenic potential, meaning that when you give it something, it is immune response, not too bad against it, although there could be some immune response, but I just want to say it's lesser than other organs. But then the other thing is the targeting of the liver is important because the liver plays an important role in carbohydrate metabolism. So you're addressing the target organ that has a problem, okay? Now, when you have a liver and heart, the organ that the gene is going to go to is the liver. Now, if it processes and does the enzyme and makes it in good amount and quantities, it will circulate and go to the other organs. The enzyme will work. But we still have to wait and see what the effect of that is, based on the clinical trials that we have right now. And then the other thing that's important is noticing that when you do these clinical trials, you have to make sure that first, the type of the vector is one that is going to reach there, and how much of it is going to be made is going to be very variable from one patient to the other. So I would say time will tell.
Thank you.
Any other questions? Okay. Getting my steps in.
We have a question at this table because we have a couple people with type 15.
Okay.
And since you only touched on that the first couple slides, would you say that that's closest to type 3A because it hits muscle, liver, and heart?
So the interesting thing is the best person to answer to that is Dr. Priya Krishnani, and I know she's here in the meeting because she's working with it.
We all see her.
Yes. Well, so there you are. So the point is, because it's a rare disease and because it actually has more of the heart and the muscle, the liver, it's interesting. It's very variable. Some patients have the liver component, others don't. So it's in the makes right now. So it's starting to be recognized. And for us to know about these disorders, when we talk about future treatments, you have to understand there's a natural history process to it, meaning you have to learn what are the long-term data about what happens to these patients and understand what goes on, and then decide, okay, what is the best way to treat them? But of course, if primarily, in this condition, it's primarily muscle and heart, and then the liver can be associated. So in this case, will targeting the liver help the muscle and heart? Is something too early to decide, but I will say that it's one of the active areas that Duke is looking at this point in time, just not me.
Hi, my son is type 3A, and we always have high triglycerides. So I was just wondering if you could talk a little bit about lipid management and what that looks like.
Okay, so that's important because lipid management, so triglycerides, so first, do you know if there's a family history of high triglycerides due to other cause? Yeah? Okay. So I don't mean it in a bad way, but the whole idea is triglyceride levels are high in GSD3A, but actually lesser than in GSD1. Okay? The whole idea is how high is high. So if it's in the range of the 200, 300, yeah, that's high, but it's manageable. If it's in the 600 and 1,000, that's a different problem. So if you have in the 600 and 1,000, and you, for example, and I don't mean you, but in general, anyone has those levels, and they have GSD 3A, also look into the family history that there's no other reason for the triglycerides to be elevated. So it could be GSD and something else causing the triglyceride. But in general, if you have an optimal diet and you take care of the amount of triglycerides that you're taking, that can limit it. I just want to say triheptanoid, actually, you think it's a glycerol, so you think it would increase the triglycerides. It doesn't. And MCT oil actually reduces also the triglyceride, because instead of breaking down the triglycerides and fat and causing ketones to be elevated, you're giving it from outside and you're inhibiting what we call endogenous, your own breaking down of the triglycerides into ketones, okay? So that's another way to do it. But again, it depends very much on what your levels are, what your diet looks like, and what's going on. Is there other factors as well? And how good your glycemic control is, okay? So there are ways to fix that, okay? The point is they're dietary, and if dietary doesn't work, sometimes we use medications. Sure.
Okay, in the interest of time, we need to keep the schedule going, but Dr. El-Gharbawy is going to be available.
Sure.
She'll be around if you have any other questions for her. Oh. Okay, shout out.
Yeah. So what So interesting enough, there's no data on that it's been used. So when I looked it up, I had to go and look at the mechanism of action and how it is. So it's called mitochondrial reprogramming. The point is, what would it do for GSD3, which is a different form? So remember, ketosis is not a factor in GSD1. They don't make ketones. So you're programming it to make ketones so that they can be able to have another source of energy. For GSD3, is that beneficial or not is something you would have to think about it a little, because they already have a lot of ketones. Their beta oxidation, if anything, is producing a lot of ketones. Okay. Yeah.
Great, thank you so much. That was excellent.